Hi, this is Brad Bullock, and welcome to this episode of Health Talks from the Inside Out.
Dr. Brad Bullock, thank you for joining me on the podcast today.
Thank you for having me.
Yeah.
My pleasure to be here.
Yeah. So you are not only one of our hospitalists here at Williamson Medical Center, but you're actually our Hospitalist Program Officer.
Yes.
Okay, and we're going to get into that here in a minute. But I first want to begin by asking you, how did you get into medicine? What drew you to the field of healthcare?
It was a little bit of an accident.
Okay.
So I'm not one of those that was 5 years old and knew I was going to go into medicine.
Okay.
No one from my county had gone into medicine for people. We had some veterinarians,
Wow. And that was in Florida, right?
Yes,
Yeah.
including my uncle.
Yeah.
But I was going to go to horticulture school originally, and then I changed my major, and then I changed my major, and I changed my major again, and so 5 times in, I was microbiology and cell science, and I thought I would do veterinary medicine, like everybody else, and I'm from a family of farmers and ranchers, but I figured out I did not have much compassion for the animals, not as much as I needed, and so I decided that was a big mistake, and my passion has always been about people. I care a lot about people, and so I thought, this is a way to combine my love of medicine, which I already knew I loved and was excited about, with my love for people. So that's how I got here.
Awesome. So when you actually got into medical school, how did you pick your specialty? Tell us what your specialty is, and then how did you pick it?
So an internist takes care of the soft parts of people, so not the bones, but everything else, and that's what I do. That's what hospitalists do. So we are internists or family practice doctors.
Okay. And also primary care physicians are generally internal medicine or family care medicine as well, right? And that's how you began your career.
Well, I did that for 23 years, but I also came to the hospital. So I was going to nursing homes, coming to the nursery, going to the intensive care unit, taking care of patients in the hospital, taking care of patients in clinic, and doing some home visits. So I did it all.
Doing all that at once.
Yeah, for 23 years. And so this job has really simplified my life in some ways because I just take care of patients in the hospital.
Yeah. Okay, we're trying to educate the community a little bit on some of the terms that we often use, and you just said something that I don't think we've defined yet on the podcast. So you said you were boarded into specialties. What does that mean?
So there are certain qualifications that you have to do after you get your MD. So as part of that, you have to pass a series of boards to show that you are competent in that area of medicine. And so I did that in 2 different areas. Usually those line up with your residency. So I did a residency in internal medicine, a residency in pediatrics. The way mine worked is I did 3 months of one and 3 months of the other, back and forth all the way through for 4 years. And then took those exams.
Wow.
And we retake them every so many years.
Okay, good. So let's talk about the role of a hospitalist. So what is a hospitalist? What do they do here at Williamson Medical Center? All the things.
So a hospitalist takes care of patients in the hospital, obviously. That is a term that was invented in 1996. So it's not even 30 years old, right? And but what we do is we take care of patients in the hospital. So in this program, we take care of patients in the intensive care unit or the other medical wards in the hospital. We consult on a lot of surgical patients as well. But we're taking care of all of those things like blood pressure and diabetes or a stroke or a heart attack. So any of those things, pneumonia, sepsis, those are all things that we take care of.
So from the time a patient is admitted into the hospital all the way until when they are discharged.
Right.
The hospitalists are the ones coordinating the majority of the care.
Right.
Yeah.
And that's one of the things that's a lot of fun is having some of that continuity.
Yeah.
Obviously, as somebody who did primary care, I love continuity. Yeah. And so that's a lot of fun for me. And we get to know these patients. When you're there for several days and you're going through something that's intense, it's not just pneumonia in 376. It's really Miss Jones.
Right. And so as a hospitalist is caring for a patient here in the hospital, you're not working in a vacuum, right? You're coordinating, you're working with many different other providers and that type of thing. Can you talk to us about that?
It's a huge part of the job. And that's an understatement to say we touch those other pieces, right? Because one of the things we do every day is we have multidisciplinary rounds.
Okay.
And that's where we sit down for an hour and we talk about every single patient on our service. So if we have over 100 patients, we're going to sit and we're going to go through every one of those patients. And we're going to talk about the goals of care for that patient and how we get them to their goals and how we get them back home, hopefully, or wherever they need to go. And that involves pastoral care, that involves nursing, that involves pharmacy. We have antibiotic stewardship, which is a special type of pharmacist that really is focusing on the appropriate use of antibiotics as part of that as well. Case managers are there, which are helping to coordinate the insurance aspects of the stay, as well as social workers who might be helping us get oxygen set up at home, or if we're transferring a patient to a skilled nursing facility, helping to arrange that. And physical therapy, occupational therapy, speech therapy have representatives there. Nutrition is part of that committee. And we are all working together to try to see the whole patient and take care of the whole picture.
That's so good, I think, for patients and family and the community to know there's so many different moving parts to this huge puzzle, and y'all are all coming together, sitting together at once, talking through those issues.
Right. And what I love about it is it's really patient-centered.
Yeah.
That's what's at the middle of the whole thing. So it's not overwhelming. It sounds like 20 different parts, but there's really one thing that matters, and that's taking care of the patient. And that's what I love about primary care. It's what I love about being a hospitalist, is that we are person-centered.
Yeah.
I don't even like saying patient-centered.
Right.
We're person-centered, and that's who we're taking care of. And that's what makes the job fun.
Mm-hmm. So let's keep going with that, because another thing I wanted to ask you about was, I was going to say patient safety and quality, maybe person safety and quality, but that's a huge part of what we do here and what we're talking about every day. So can you talk about, I wanted to see if you could talk about some of the main kind of initiatives that we have under that umbrella. Maybe we start with high reliability organization. What is that? Why are we focused on that?
Okay. Of course, I love to talk about this stuff.
Yes,
so
I know.
This is
Give me
my
whatever you want.
jam.
Yes, this is great.
To talk about. So high reliability organization, I wish the community knew how big a deal that was.
Yeah.
This is something that they do with nuclear reactors, right? This is something that airlines do to keep from having, crashes in the air. This is organizations that take care of very scary things, very risky situations, and we're bringing that to Williamson, and I love that.
Yeah.
And we're not the first hospital to do it, but it is fairly novel for that in healthcare. Not a lot of hospitals do this. It's a big lift, or it seems like a big lift because there's a lot of pieces to it, but it's really about getting safety first and foremost in every single thing we do.
Yeah.
Every meeting we have, every patient encounter, everything we're doing, we're thinking about that. Whether it's changing a light bulb or, replacing a heart valve, it doesn't matter. That's what we're thinking about. And it's got several components to it. Let's see if I can remember them.
Yeah.
So preoccupation with failure is the first one.
Okay.
That's kind of obvious, I think, what it's saying, but we're thinking about where can something go wrong at every step of a process.
Okay.
So it's really getting in the weeds.
Before it happens.
Yes,
you want to think about
preventing
it.
it. It's getting in the weeds to prevent that problem. So thinking about each step. If there's 20 steps, you're thinking about 20 different things. What could go wrong with each one of those? How do we solve it? Next is sensitivity to operations. And that is where you back up and say, okay, big picture. What do we need to be thinking about? Not every little step, but were we staffed appropriately? Was there good lighting? Were people doing hand washing, as they were supposed to? All of those things that keep the system safe. And also another piece of that is culture of safety, is thinking about, do you have the ability to speak up? And I don't care if you're the janitor or if you're our top surgeon. Right. Do you have the ability to speak up and say, hey, I'm concerned about something?
Right. I see something that doesn't look right. Or,
right.
Yeah.
That's part of that too.
Yeah.
And then reluctance to simplify is the next thing. And it's kind of an interesting one, because in medicine, what we're trained to do is think about Occam's razor. And what Occam's razor is if you have 50 things going on with the patient and you can narrow that down to one diagnosis, that's probably what they have, right?
Okay.
So if it all fits under that one diagnosis, that's probably what they have.
Okay.
But this turns it on its head and says, okay, so great, you figured that out. What else did you miss? What are the other pieces of the picture?
Wow.
So yeah, they have chest pain, they were having a heart attack, but did you address their diet? Did you address their sleep? Did you address their exercise? All of those other pieces.
Right.
Did you think about that? So I love that adds complexity to what we're thinking about, doesn't let it get too simple.
Yeah.
The next thing is deference to expertise, and that's a great one. And what it says is that we're not a team of experts, but we're an expert team. So everybody brings their skills, everybody brings what they see, and you can always speak up and you can always make a difference.
Right.
So I like the idea of not having you in a role and it's your job,
Right.
it's all of our job
Right.
to keep patients safe.
Right.
Every one of us needs
So instead of giving the expert label to certain roles in the room, is what you're saying, we all get to wear that.
Exactly.
Yeah.
And the last one is commitment to resilience. And that means that we learn from our mistakes, because no matter how good you are, you're going to have mistakes. You're going to have things that you could do better. And even the best of us can always do better. So it's not ignoring that. It's anytime something wasn't 100% what it could have been, what do we have to learn? How do we make ourselves better? How do we do it a little bit better next time? So those things come together, and ultimately it's an organization focused on safety.
Yeah. And let's talk a little bit about what those safety huddles look like, because you talked a minute ago about how the hospitalist team gets together, a big group of people, not just the hospitalist.
Right.
Other people go patient by patient. But what is the safety huddle? It's a different meeting that happens. What is that?
So it is a meeting that is devoted to that, and it's really thinking about your day to make sure, like, was there something that happened overnight that we need to be aware of?
Right.
What's happening today? How are we staffed? Do we have any patients that need special attention or special services that we need to be coordinating that to get that into place?
Yeah.
So it's really a lot of those components that I just spoke about, those 5 components of about a high reliability organization, is putting those into practice is what it is.
Yeah. Okay, so another big safety and quality initiative that we're continually talking about are hospital-acquired infections. People might hear them referred to as HAIs. So what are HAIs, and what are we doing to prevent them?
They are what they sound like, so infections that you get in the hospital.
Okay.
So if you come into the hospital with an infection, that's not an HAI.
Okay.
But it's one that you get in the hospital. The point of our HAI task force is to prevent these infections.
Yeah.
So we know if we reduce catheter use, we know if we reduce Foley use, that if we use special precautions regarding high-risk surgical procedures, that we prevent a lot of these infections. And I'm super proud that our hospital has a very low rate of infections in all of those categories, and others that just trace themselves back even to hand washing or appropriate use of antibiotics. People have heard of MRSA infections, people have heard of C. diff infections probably. We have very, very low rates, and it's because we're doing the right things on the front end
Right.
rather than trying to fix it on the back end.
Yeah. And just one more time, real quickly, define a Foley and a central line.
Oh, I'm sorry.
That's okay.
So a Foley is a catheter that goes into the bladder,
Okay.
just so that you don't have to get up to urinate, and so
Right.
it constantly is draining the urine. And they're necessary in a lot of situations. I mean, anesthesia, for example, you're going to need to have that, very often after a major surgery or a pelvic surgery. So they're necessary. Central line, same thing. You might need that for certain medications that can't be given through a regular IV.
Okay.
But if we can get it out today, we're going to get it out today. If not, if we can get it out tomorrow, we'll get it out tomorrow.
Yeah. So let's talk a little bit about falls, because that is something that we are very vigilant with when people are in the hospital, obviously not wanting to have any patients fall. So let's talk about that.
So we have a committee devoted to fall prevention, and it's a big group, multidisciplinary group that comes together. I don't know, there's probably 30 people on the committee. And we are trying to think about it from every single aspect. We know that medications influence falls. We know that when people get delirious or confused in the hospital, that affects falls. We know that if the bed height can affect falls, even. So there are so many things that go into it. And so every patient is given a fall score. So what we think the likelihood is that they will fall, and there's tools we use to assess that. And then we make sure the appropriate interventions are in place. And we track that. We track it by unit. We track it by time of day. We track it by who was the nurse involved with that patient. We look at the medications that patient was taking. So we're looking at all aspects to try to prevent that. And people, I don't think, recognize how much attention to things like that may not be obvious, when you come in, that we're doing to make sure that we're keeping people safe.
And on the falls topic, is there something that we could let community members know now, maybe before they are a patient in the hospital, or if they have a family member? Like what's a tip they can do to help partner with us to make sure we don't have
I think something that comes up fairly regularly that, it just makes us all go, oh, is patients that say, well, I didn't want to bother anyone.
Yeah.
And so they're high fall risk, they shouldn't be getting up on their own, and they don't want to be any trouble.
Right.
And so they get up on their own and then they fall and they hurt themselves. And so we really do mean it when we ask patients to ask us, to come and help. Yeah. And anybody on the floor can respond to that call light. Anybody on the floor can help somebody if they need help. One of the things we've done in that line, which I think is so cool, and we'll probably talk about patient and family advisory council.
I definitely want to.
So this is a little foreshadowing for that, but one of the things that we did with that group is we had them review some of the documents that we use related to fall prevention, and they had a great idea. They said that the document that we presented to encourage patients not to get up, that there were a couple of things we could do to make it better. Yeah. They said, let's put it in wording that makes it obvious it's a partnership. That you're committed and we're committed. Right. And so we now sign the form, and we ask the patient to sign the form as well to say, yes, we are committed and these are the steps we'll do to make sure that you don't fall while you're in the hospital. Right. The other thing they did besides just having everybody sign is they changed the language some to make it clear that mobility was important too. They thought that we should just combine those things together and not just talk about it's important not to fall, but it's also important to move because movement can prevent falls if done appropriately, right? So we put those things together, and it made it so much more, I think, helpful, and people can relate to it. Whereas before it seemed almost like don't get up. And now it really seems like a partnership. And I love that. Yeah,
and to reiterate, make sure everybody hears it, it's never a bother. It's never an inconvenience for a patient or a family member to reach out and say, I need help, I want to move, I want to get up. So don't.
No, I don't think you will find us rolling our eyes or complaining. We want that.
Right.
Yes, please.
Good. Okay. Let's talk a little bit about quiet nights. That's something that people might have heard us talk about or seen some signage. We have a quiet nights initiative.
Yes, we've had that for a few years now, maybe 3 or 4 years, I'm not sure. But where that comes from is, I think sleep is almost the forgotten piece of your health, right? When you come in the hospital, people almost expect to be awakened all night long and not get any rest, and we really are trying not to do that. So we have changed some things. We changed the timing of medication so that there's a greater gap at night so that people have more chance to sleep. That way they're not having a nurse come in quite as late or quite as early to give the medications. The rooms are pretty dark now in the new part of the building. There's lighting on the floor to help with moving around, and it's easy to get the lights on, but it is fairly dark, so that helps people as well. And we even changed when we collect vitals and how we collect vitals. So maybe the first night we go ahead and get vitals throughout the night, but then it's easy for us to adjust that schedule so that we skip vitals once in the middle of the night for patients where that's appropriate so that they can get a little bit better rest.
Right. And so it doesn't mean that we're never going to come in the middle of the night, but it does mean that y'all are adjusting care appropriately for each patient and trying to limit interruptions.
Well, even those patients that are on quiet nights, the nurse is coming in the room, sneaking in the room quietly just to make sure someone is asleep, resting comfortably, and then leaving. But that's different than coming in and checking your vitals where you'd really be awakened. Yeah. Okay. So the point of all of these pieces, the HRO, the HAI task force, the falls committee, the quiet nights, all of that together is about our commitment to zero harm. And that's what I love about these pieces, that they all work together. It's not so complicated when you recognize the patients at the center of this, and it's about keeping them safe.
Yeah, everything revolves around that.
Right.
Yeah. Okay, you hit on our Patient and Family Advisory Council a minute ago. So let's get into that. What is that? What are they helping us do? Why is this important?
I don't think I'm allowed to have favorites, but it's sort of one of my favorites.
Favorite projects,
I love it. I love the HRO, and I also love the PFAC, Patient and Family Advisory Council. And I'm really happy to be co-chair of that right now. So it's been about 2 years that we've been doing it.
Okay.
Yeah, and it's a lot of fun. The reason why it is so much fun is because you really are getting information from the people you need to get the information from, right? So the patients and families are there, and this is a really committed, dedicated group of people that are showing up. They are not just checking the box.
Right.
When they show up, they want to know, what are we talking about? They want to dig in, they want to get dirty, figure it out, and make it better.
And how many people are on?
There's about 12 from the hospital and about 12 from the community that are there. And we have dinner, and we always have a few topics that we're going to talk about. And sometimes we go completely off in another direction because somebody brings something up. Right. We're there to listen. That's what we're there for. And they bring us anything that they want to, and we talk about it. Okay, so a great example of what the PFAC does and why I love it is we have a community member, John, who wanted us to try to figure out a way to connect with patients after discharge. Yeah. And we thought about several ideas, but what we ended up doing is creating a call program. Yeah. So we call a lot of patients that leave the emergency room or are discharged from the hospital for follow-up just to check in, see how they're doing. Did they get their medicines? Were they able to get to their follow-up appointment? How are they feeling at that point? And I love that we're doing that. Yeah. I also love that our CEO really wanted us to focus not on asking questions or doing things that would maybe raise our ratings on a survey, but the things that would take care of the sickest patients. So we're focused on those patients with the most complex diagnoses or are underinsured or uninsured. That's who we're taking the time to call, and I love that that's who we're investing in.
Yeah. So if someone gets a call from us, and they've recently been here, take the call
that's what it's about.
And talk to us. So we've covered a lot. Is there any additional thing you want to add that maybe I didn't ask you about?
So we have recently hired a couple of new doctors to help with admissions. So our biggest time for admissions is afternoon, early evening. Okay. So we hired 2 docs to work those hours. They're stationed in the emergency room, and so they are picking patients up as direct handoffs from the ER, which I love, the direct communication there, and then we're getting them plugged into the hospitalist system and hopefully upstairs a lot faster by doing it that way.
Oh, that's great. And are we coming, it just made me think, when you said that, are we coming into the busy season too, here with flu season coming? And
very much. So, we consider November, December, January, February the busy season, so we're right on the verge.
Yeah, so just in time. Good. So as a hospitalist, you really are at the heart of patient care every single day. What's the most rewarding part of your job?
There are a lot of rewarding parts to the job. Yeah. So anytime we get to connect to a patient, a person, and really make a difference, and it's huge. So we have a position of great honor. It's such a privilege for people to share what they share with us, and for us to be able to be led into their lives to have a chance to make a difference. So it's pretty special, and there's a lot of examples of that. A couple of things the hospitalist just recently did that I thought were so cool. We had a patient that came in with a certain form of dementia that doesn't respond well to certain medications if they're on it. And he was on one of those medications from home, and it made him extremely confused, extremely agitated. Just stopping that medicine, just looking at the whole picture and stopping that medicine, we fixed him. That's what it took. That was great. Yeah. Another example is we had a patient who had heart murmur and an infection, and the first test did not show there was a problem there, which is not uncommon. Okay. But we didn't stop. We kept turning over stones, and so that hospitalist was able to find out the real cause of what was going on, and it was an infection on the heart valve. And she was able to get it replaced. She was on the appropriate antibiotics. She's thriving now. So I love stories like that, and there's a million of them.
Yeah. So before we end, is there a final takeaway, like a piece of advice or just a lasting thought you want to leave community members with about the care they should expect from Williamson Medical Center and Williamson Health, how they'll be treated here?
So if I could have everybody remember one thing, it is that this is a partnership. So you're not showing up to be fixed. We're not the fixers. You're not the one that needs help. We're working together to solve a problem. And our main job is to listen to you. So don't let us forget that. Be sure and speak up. Be sure and tell us what's going on. What do you need? What are you afraid of? What are your goals? That's important to making sure you get the care you need.
Yeah. And again, it goes back to it's never a burden. It's not a bother.
Absolutely not.
Speak up. We're here to do this together.
That's what it's all about.
Yeah. Dr. Bullock, thank you so much for coming in and sitting with me today. We are so proud of and grateful to you and the rest of the hospitalists, all the caregivers here taking care of our patients. We're just so proud.
It's an honor and a pleasure. Thank you.